Hello everyone. So this is our second video in the discussion, and we'll start from whatever we led from yesterday. Okay. So this is our second video. So we have completed up to second question yesterday. Now this is the third question. So on the third day after the acute anterior myocardial infarction, a 55-year-old patient complains of dull ache behind his breastbone that can be reduced by bending forward and of dyspnea. Objectively, AP 140 by 180 heart sounds are dull. ECG result AF with frequency of ventricular contraction at the rate of 110. Pathological Q wave and ST segment raising in the right chest leads. The patient refused from thrombolysis. What is the most probable diagnosis? So again, what we will do? We will do the keywords. Okay. So first, it is a 3 day after acute MI. Okay, dull pain and what that can be reduced by bending forward. Then we have high AP, heart sounds are dull, heart sounds are dull. ECG results atrial fibrillation with frequency of ventricular conduction means rapid ventricular conduction. Okay. Then we have pathological Q wave and ST segment raised. So these are the important signs we're getting from this question. So what will you suspect in this? Okay, so here there is options are acute pericarditis, pulmonary embolism, Tietze syndrome, dissecting aortic aneurysm, and Dressler. So if you don't know anything about it, we need to first exclude the options, right? So first we will exclude what is here. Here pulmonary embolism, right? It's pulmonary embolism. Pulmonary embolism. Second one, so make it second, right? We should put this in number 2. Number 1 is acute pericarditis. Number 3, Tietze syndrome. Number 4, dissecting aortic aneurysm. And fifth one is Dressler. So first we need to know about the diseases, then we can differentiate, right? So what is acute pericarditis? Acute pericarditis is the inflammation of the pericardium, right? Then we have pulmonary embolism. We all know about that. What about Tietze? Tietze syndrome. It's we can say in simply it's costochondritis. Okay, so costochondritis means the cartilages of the chest, they will have inflammation, so we'll have the sign of chest pain, obviously, plus swelling or lump. Then there is dissecting aortic aneurysm. So if an aneurysm dissects, okay, fractures, it will give us a classical tearing pain. Tearing pain. Then we have Dressler's. It's an autoimmune process which is caused post MI mainly, but the time is 2 to 3 weeks post MI. So pulmonary embolism, we know there is emboli. It may be in the bifurcation, it may be any artery or vein in the lungs. Okay, and we have acute pericarditis. So here there are some ECG changes. In pulmonary embolism, we'll have a classical formula. It's S1 Q3 T3. So S1 means there will be pathological S wave in lead 1, there will be pathological Q in lead 3, and inverse T in lead 3. So this is pulmonary embolism. What about acute pericarditis? We will get ST elevation, but it is non-specific, right? ST elevation we can get anywhere, like in MI also we will get ST elevation. But the classical sign or keyword you can say here is the pain which we get from acute pericarditis is relieved by bending forward. So pain decrease by bending forward. Why this happens? Because it reduces the pressure on parietal pericardium, okay, while inspiring. So now we will go back to our answer question. Here what we have. We have history of acute anterior myocardial infarction. So here it also can be post injury or infection. So it can be acute pericarditis, it can be Dressler. Okay. Then we have pathological Q and ST segment raising. So we don't have this formula and ST segment elevation. So pulmonary embolism we exclude. We don't have any swelling or lump, so exclude TITSE. We don't. The pain is here. Complaint of dull ache. Okay, dull pain. So it's not tearing like pain. Okay, so we exclude dissecting aortic aneurysm. Now we left with acute pericarditis and Dressler. So here also history of post MI, here also history of post MI, but we need to see the time. Okay, it's third day after the acute anterior myocardial infarction, but in Dressler it is autoimmune process and it takes approx 2 to 3 weeks. So here also we exclude. The answer is acute pericarditis. Okay, so here the answer is acute pericarditis. Then next, a 54-year-old man was admitted to the hospital with complaints of sudden intense headache in occipital region and vomiting. In the medical history, moderate arterial hypertension. The patient was taking thiazide. 3 days ago, he consulted a therapist about intense headache that was suppressed by analgesic. Objectively, consciousness is confused, left pupil is mydriatic, evident photophobia and tension of neck muscle, left side hemiparesis with increased muscle tonus and reflex, body temperature low, rash is absent, APE 230 by 130, pulse 50, breathing 12. What is your preliminary diagnosis? So again, what we are getting from this? So it's 54-year-old man, complaints of sudden intense headache in the occipital region. Okay, Medical history: moderate arterial hypertension. The patient was taking thiazide. 3 days ago, consulted therapist about intense headache that was suppressed by analgesic. 3 days ago, he was consulted a therapist about intense headache that was suppressed by an analgesic. Okay. Consciousness is confused. Consciousness is confused. Left pupil mydriatic, evident photophobia and tension of neck muscle. Left-sided hemiparesis with increased muscle tonus and reflex. So let's exclude some options first, so we can get to something. So here we get left-sided hemiparesis with increased muscle tonus. So we are getting focal symptoms. Okay, so as we are getting focal symptoms, we can exclude like migraine, because in migraine we rarely, like directly, it is not associated with any focal symptom. Then it is only left-sided hemiparesis, so we can exclude misthenia because it will involve generalized. Okay. Then also sclerosis we can exclude by sclerosis. Actually, it is not associated with any of these symptoms. Like we have a history of arterial hypertension. Okay, so we keep it here like that. Acute bacterial meningitis. Here we have body temperature is low, so if you have meningitis, we will get the toxic syndromes. Okay, so we don't have any toxic syndromes here, so acute bacterial meningitis we exclude also. So we suspect here any hematoma. Why? Because the most common things which occurs in hypertension with old age. Okay, hypertension with old age, it associated with any hematoma or stroke, like this. Okay, so there we can get tension in neck muscle, so we can get focal symptoms like paresis or paralysis, like that. So we suspect here hematoma. Sorry. And we have some consciousness is confused. So this question we can attempt like that. What? First one is arterial pressure high, and we have age, so we suspect hematoma first. But this is not a tough question, but they can make it tough by giving other options like other hematoma and hemorrhages. So we need to know about the hemorrhages and hematoma. So first we talk about that. So what we have? How many types of brain hemorrhages or hematoma? First we have. First, what is the difference between hematoma and hemorrhage? So hematoma, there we have oma, like a tumor like. So it is confined by boundaries. So if the bleeding is confined by boundaries, we call it hematoma. But if it is diffuse or profuse, we call it hemorrhage. Okay. So first we have epidural or extradural. I'm not going in deep of the meninges. Okay, so if you don't know, you need to learn about that. Second one is subdural. So you can know about this like name. Extradural, so it is outside the dura. Subdural, it is inside the dura. It is hematoma. It is also a hematoma. Third one is subarachnoid hemorrhage, and the fourth one is intracranial hemorrhage. Intracranial hemorrhage. So we have these four classification. Okay, now we'll talk about these four in a briefing. So they can give you options like this. Okay, this can make you confused. So we need to differentiate among them. So first, what is epidural or extradural hematoma? So, and then subdural hematoma. So we'll talk about these two first. As subdural is in our options, we will talk about this first. So subdural hematoma, it is mainly seen in aged, okay, aged patient. And what is the cause of this? This caused by bridging vein rupture. Bridging vein rupture. And what we can see in CT? We can see in CT a crescent shape, or you can say banana shape. What about epidural hematoma? But before that, I need you to remember one thing, that is, okay, so epidural hematoma we get outside the dura, okay, and it is caused by mhm, it is caused by middle meningeal artery. And we can see a lemon sign there. I will show you lemon sign. And most important, it is, we will get the term lucid interval. So what is lucid interval? It's like the patient will come with history of accident or fall, and then they say that after the fall they are okay, they don't have any problem, they went home or like that. But after 1 hour or 2 hour or 6 hours, they will come to you with a complaint of unconsciousness. So after the accident they are all okay, but after few hours they get the symptoms of consciousness loss. Okay. In subarachnoid hemorrhage, the classic sign you will get that the patient will complain you as worst headache of life. And in intracranial hemorrhage, you will get also some, like we can differentiate it by CT and focal deficits prominent. In subarachnoid hemorrhage, what you will see in CT, you will see like it is caused by rupture of actually berry aneurysm, mainly berry aneurysm. And if you say what is berry aneurysm, it's an aneurysm which is seen mainly in one of the arteries, communicating arteries of circle of Wills. And what is circle of Wills? So these are important topics. Okay, so we need to know. Just circle of Wills actually is the network of blood vessels which is in our brain. Actually, brain is a very vital function, you all know. So, it is created like this way. So we get two blood supply from uh, anterior and posterior to the brain. Okay, and this is the connection of these two system, anterior system and posterior system. So if one system get damaged, we will have enough backup for our brain to survive. So circular pulse, you can see something like this. I will say the name first. I will draw it. So you will see something like this, a network. Okay, I will show you in real image, but first you need to know the names. So this is our internal carotid artery. This is our vertebral artery. This is our basilar. So what we see is this portion. Okay, this is the posterior circulation. This is the posterior circulation, and this one is anterior. So we have this one is anterior circulation, and we have posterior circulation, and you can see in this image that they are communicating here. Okay, so this is ICA, like internal carotid artery. This is middle cerebral artery, middle cerebral. These are anterior cerebral, and you can see the two anterior cerebral are connected by one artery. So this is our anterior communicating. And if this is our anterior communicating, we should have one posterior. So this is our posterior communicating. So there is one very like common question comes from where you can expect it in FMG more than Krok. This like which artery is not a part of circular pulse. So this middle cerebral artery, you can see this is just a lateral artery. So it is not included in the circular pulse. So this is circular pulse. Okay, this is the circle of pulse. Okay. So our main focus, as we said about berry aneurysm, this is the most common site of berry aneurysm. Okay, anterior communicating artery, and if this rupture will get our subarachnoid hemorrhage. Okay, and one more artery. This is the, so we have middle cerebral artery, we have anterior cerebral artery. So we should have posterior one. So this one is posterior cerebral. Okay, this is our circular pulse. So as you said, now we'll see some images. So first let's go to the question. Subdural hematoma, we have aged person, bridging vein rupture, crescent shape, banana shape. So here there is aged person and we have hypertension, and so if there is a hemorrhage, we will suspect it as subdural hematoma. Okay. So we saw the images. Okay, so I think it's clear now, and this is the so here we have the answer of subdural hematoma. Okay, And why not sclerosis? Because in sclerosis we will have multiple symptoms. Okay, not like one left-sided hemiparesis with increased muscle tonus and reflex. Not like that one symptom. Okay, in multiple sclerosis we will have multiple symptoms with weight loss and worse prognosis. Like this, we will have a history. Okay, so we exclude this also. So for this video, I think it's enough. We'll continue in the next video. Thank you. So now we'll see some images of different type of hematoma and hemorrhages. So first one is subdural. It looks like something like this in city. As we told, it is crescent shape. So it will look like this in city. And next one is epidural. So in epidural hematoma, what happens? The blood gets accumulated in epidural space. So it will look like something like this. So as we said earlier, this is crescent shape, or you can say banana shape. And here it is lemon shaped. And how we get the lucid interval? Like this bleeding occurs not instantly, after a few minutes or hours, you can say. So it will get accumulated here, and this portion bulge out into the parenchyma, and there you get the lucid interval after some minutes, okay, or some hours, sorry. And then what happened in subarachnoid? In subarachnoid, as we said earlier, we'll get our circle of wheels, right? And the hematoma will be here, or we can say hemorrhage more specifically. So here you will get a white dot in city, and in the intercranial you will see something like this. There will be patchy dots in parenchyma, right? White patchy dots in parenchyma in intracranial hemorrhage. So these are the four hematoma and hemorrhage. You need to remember the photos. Most importantly, these three intercranial, it's rarely comes in exam. So subarachnoid and subdural and epidural. Okay, thank you.